Hey guys, I'm Payam. I'm one of the emergency physicians. I used to work at Nepean as the ultrasound fellow with VJ, the AD physician there. Now I'm pretty much a staff here at Concord. I'm doing a DDU in the emergency. So pretty much the exams are in August. I think with you guys, same thing. So today I'm going to cover the ultrasound in trauma, technically EFAST. So before you start recording, can I just double check to see when I share? No. Hi, this is Payam, one of the emergency physicians. I used to work at Nepean Hospital with VJ, the emergency physician there, as the ultrasound fellow. These days I'm working at Concord Hospital, and I'm doing my emergency DDU. So today we are going to talk about the ultrasound in trauma, so mainly covering EFAST. So just as a disclaimer, the images and the slideshows that I'm using are actually put together by Dr. Vijay Manival, the emergency physician at Nepean Hospital and DDU holder of the emergency unit. So today we are going to talk about how to do the EFAST, how to identify free fluid in three main cavities, pericardium and pleural effusions, which would be the pneumothorax in the context of trauma, and the free fluid in the peritoneum. Then we are going to talk about how to increase the sensitivity of picking up free fluid, techniques of that, and also some pitfalls. So EFAST generally started as FAST, focused assessment with sonography in trauma, which was used to just mainly look at the free fluid in pretty much peritoneal cavity and in the pericardial area by looking at mainly four spots: the right upper quadrant, left upper quadrant, suprapubic, and the sub-xiphoid. Then several years ago, the E part of it, which is the extended EFAST, was added to it, which is basically looking at the lungs anteriorly for the pneumothorax and at the basis for the detection of the hemothoraces. Depending on how much fluid is there, there are some studies showing a sensitivity of about 70 to 80% and specificity of about 90 to 100%. And for the pneumothorax, especially in trauma, it's interesting with the EFAST, the sensitivity of EFAST picking up pneumothoraces, especially small pneumothoraces, are much better than chest X-ray. One of the things to consider here is that in trauma, usually patient is supine and we are doing a supine X-ray, which is not that great for picking up, especially small pneumothoraces. So ultrasound becomes much more accurate. So the whole idea for picking up the intraperitoneal fluid is that there are some spots that are dependent areas when the patient is supine, and trauma patients are pretty much almost exclusively supine, which are the Morrison's pouch, the perisplanchnic area, and the pelvis, and the paracolic gutters. And that's where we are looking at with the ultrasound in the FAST. How much of fluid do we need to be able to see it in the ultrasound? So in the supine position, generally speaking, we need about 600, 700 mils to be able to pick it up. And to increase the sensitivity of that, we can put the patient in the Trendelenburg position. And with that, we should be able to pick up fluids as less as 400 mils. And with the pelvic fluid, it's much more sensitive. So even about 100 ml of fluid, we should be able to pick up. What is not going to be picked up in EFAST? So in the earlier stages of bleeding internally, we might not be able to pick up the EFAST, and we might not be able to pick up the free fluid, and that's the importance of repeating the exam. And that's one of the advantages of ultrasound over other imaging modalities like CT. We can repeat it. If it's not positive in the earlier stages of trauma, it may become positive later on, especially if the patient is hemodynamically stable early on and then becomes hemodynamically unstable later on. We need to repeat the exam. It might miss very small pneumothoraces, but still it's much better than the X-ray. And it's not good to pick up hollow viscous injury, and it's not good for retroperitoneal bleeding. It might miss the retroperitoneal bleeding. We can do the FAST in blunt or penetrating trauma. We can do it whenever we are suspicious of a cardiac tamponade and trauma in pregnancy. And if there is any unexplained shock or hypertension, we can do that EFAST to see if there is any blood loss internally. Now, when we do the EFAST, there are two key questions. One is there any free fluid anywhere? And that anywhere can be in the pericardial area, in the pleural area, or in the area. And the second question is there any pneumothorax? So there are some pitfalls with the ultrasound in trauma and doing the EFAST. One is that when we see fluid inside the peritoneal area, it's very hard to distinguish blood from ascites. So for the people with ascites in the background, it's sometimes very, very hard to distinguish, unless if it is organizing. Even that, pretty much very hard to say whether it's clot or whether it's some septations of the ascites itself. And it's not good for solid organ injury. The other thing is in the patients with high BMI, ultrasound is not, it might not be easy to get diagnostic images. So we might not be able to comment on the images that we get. And if there is surgical emphysema, that can interfere significantly with the quality of the images. So we might not be able to pass through it to see what we need to be able to see to be able to comment whether it's a positive EFAST or negative one. Obviously, we can sometimes over-reliance on the ultrasound can be problematic, especially when we are deciding about unstable patients. And we are not going to, and if doing that ultrasound, especially if it's taking a long time to get the appropriate images, is going to delay the transfer of the unstable patient to the theater. That's another pitfall that we need to avoid. The last thing is sometimes blood can be missed because of the conception that the blood should be anechoic, but obviously the clot is already formed, especially in the trauma, which is not super acute. If there are several hours post the injury, after the injury, it can be already clotted, so it might be echogenic. Now, the technique of doing EFAST, usually the patient is supine, or we can actually put the patient in the Trendelenburg to increase the sensitivity. And there are 6 spots that we look into. Generally speaking, 2 anterior spots for the detection of the pneumothorax, the right upper quadrant, left upper quadrant, sub-xiphoid, and pelvic area. Now, in which order we do it, it depends on the clinical situation. There is no right or wrong way of doing it. People who started doing initially fast a decade ago or so, and then the extended part got into their practice, they still do that pretty much intraperitoneal ones, the right upper quadrant, left upper quadrant, and the pelvic and the sub-xiphoid for the heart first, and then they look at the lungs. I personally, in the trauma setting, go for where the pathology which can kill the patient first is, and the ones that we can fix, and should we fix them in the pretty much emergency department quickly first. So I tend to start with the anterior parts, looking at the pneumothorax first, especially if it is suggestive of potential pneumothorax. It can and it should be fixed straight away. Then I go for the sub-xiphoid, looking at the heart to see if there's any signs of tamponade, because then again, it can and it should be fixed straight away. Then I look at the intraperitoneal fluids by the other by looking at the other three areas. There are some talks about trauma sweep, starting from one side, going up, going down. That can help preventing missing a view. But again, depending on clinical situation, we can choose which area to look at first. Now, regarding the choice of the probe and presets, generally speaking, for the pneumothoraces, the linear probe on the lung presets has the best quality and most accurate one. Having said that, we don't necessarily need to change the probes, and usually most of us use the curvilinear probe for all of them. We just use the lung presets when we are looking at the pneumothoraces, and then we change it to EFAST preset when we are looking at elsewhere. If there is no EFAST preset on the ultrasound machine that you're using, abdominal ultrasound, generally speaking, does the same job. We can actually even do it with the phase probe. It's just a bit of a less quality of the image than the curvilinear when it comes to abdominal exam. But generally speaking, the best probe would be the linear. If you don't have a linear probe on the machine that you're using, there's no problem using the phase probe, doing the whole exam. Now, when we are looking at the right upper quadrant, the patient is usually on the supine position and or Trendelenburg to increase the sensitivity of picking up smaller amounts of fluid. We use the curvilinear, preferably, probe on the EFAST setting or abdominal presets, and it's longitudinal on the long axis. What we want to see is pretty much we put the depth at where we can see the spine, and we sweep through the kidney. We want to see the interface between the kidney and the liver, the Morrison's pouch, to look for free fluid, which would appear as a band of anechoic area if it is not clotted blood. Then we want to go a bit higher, looking at the base of the lung. Initially, we want to see the lung curtain to make sure there's no fluid in the lateral part of the pleural space. Then we increase the depth and have a look at the base of the lung. Ideally, what we want to see is that mirror image of the liver on the other side of the diaphragm. The other thing that we want to see is this spine. And as you can see, we call it a spine sign. So technically the diaphragm and the air in the base of the lung is obscuring the spine. And as the patient breathes in, it just obscures more of the spine, which is a confirmation that the lung is aerated and there is no fluid in the base of the lung. Obviously, if there's any fluid in the base of the lung, the ultrasound beam will pass through the diaphragm and through the fluid, and you can keep seeing the spine beyond the diaphragm. But in this normal one, first of all, we can see the mirror image of the liver on the other side of the diaphragm, and it obscures the spine. And this is an example of a fluid at the base of the lung. For the perisplanchnic area, and one thing that I forgot to mention is that for the right upper quadrant, usually the spot to put the probe on is the mid-axillary to anterior axillary line. For the perisplanchnic area, it's usually obviously on the left side and mid to low, posterior axillary line. And usually we keep the probe and back of our hand would be touching the table to be able to get a good view of the spleen, because what we want to see is preferably something like this, with the spleen in the view, the diaphragm, and the kidney. Because the fluid can go anywhere between either a spleen and the diaphragm or the spleen and the kidney. This image is quite a good one, and unfortunately, usually we are not that lucky to get all three structures in the same picture. We might need to sweep once for the space between the spleen and the diaphragm, and go find the kidney in another set of image, and again sweep to get the whole space between the spleen and the kidney. But in this one, we are getting the whole clear structure in just one image. And again, the same thing after we are done with the pretty much perisplanchnic area, we go up, we check for the lung curtain, and we check for the spine sign to make sure that there is no fluid in the base of the lungs. So there's a bit of a glitch with my PowerPoint. I'll just close it and open it up again. Okay, so this is an example of blood between the spleen and the diaphragm, and this is a diagram of that. And in this one, pretty much there is fluid everywhere. So there is free fluid between the spleen and the diaphragm. There is free fluid at the base of the lung. And as you can see the continuation of the spine instead of aerated lung obscuring the view of the spine. You can keep seeing the spine beyond the diaphragm. And in this image on the right, you can even see fluid between where the kidney would be, between the spleen and the kidney. Then we move on to the sub-xiphoid area to look for pericardial effusion. I might go through this quickly because I'm pretty sure you know much more than pericardial effusion and signs of tamponade than me. So just go through that quickly with the pericardial effusion. Then we go to pelvis. In the pelvis, we do two sweeps, one in transverse view and one sagittal. Again, we are using the curvilinear probe in the abdominal setting or EFAS setting, and patient in the supine or reverse triangle. So I said typed in error. For pelvic area, we put the patient in reverse Trendelenburg with the legs down to increase the sensitivity, so the fluid would go more in the pelvic area. So this is the transverse pretty much sweep. So you start from pretty much all the way caudal, preferably seeing the symphysis pubis, and then fanning upwards all the way beyond the bladder. And what we would see is that if there is any fluid, where we expect it to be is in the female patient, usually in the pouch of Douglas, between the ureter, sorry, between the uterus and the colon with the rectum, and in the males usually it's between the bladder and the rectum. So this is sagittal view. So as you can see, this is a female patient, bladder, vagina, cervix, uterus. So technically, if there was any fluid, usually we will see it in the pouch of Douglas between the uterus and the rectum, which would be roughly there. And again, with the sagittal, we go all the way to one side until we can see the pelvic vessels, and sweep all the way down to the other side until again we can see the pelvic vessels. Sometimes we see that the blood pretty much anterior to the bladder, which is very rare. I personally haven't seen any of these examples as in blood anterior to the bladder. Very rare. Usually it's posterior to it. Usually it's between the bladder and the rectum. For example, this is an example of the blood between the bladder and the rectal gas. And this is an example of a female patient with the free fluid between the uterus. So this is the bladder, this is the anteverted uterus, and this is the free fluid between the uterus and the bowel gas, the rectum gas. And this is a sagittal sweep. And as you can see, bladder, vagina, cervix, uterus, bowel gas, and there is free fluid. Pretty much this is a huge free fluid in the pelvis. So there's free fluid in the pouch of Douglas as well as anterior to the uterus, and as you can see, there is some echogenicity inside the fluid, which is suggestive of blood clot in this context. Now for the lung part, we are looking for the pneumothorax. So obviously the patient is in the supine position. Trauma patients are in supine. So we look on the pretty much right and left on the uppermost part of the chest. It's usually around the T4-5 area. And what we are looking for is the lung slide. In this example, they have used the linear probe, but obviously we can use the curvilinear, and usually we do use the curvilinear or face probe for that matter if we don't have the curvilinear, but it should be on the lung settings. Then on the M mode, we are looking for this seizure sign. So technically, pretty much the linear sort of lines are chest wall soft tissue, and the speckled area, which is like a seashore, is the area after the diaphragm, which is just kind of just artifact, suggestive of air not being in the area. so no pneumothorax. So if there is any air in the pneumothorax, then we will have the barcode sign or the stratospheric sign with the linear lines going beyond the pleura in the M mode. If the pneumothorax is not going all the way around the chest, when we are sweeping around, we might see the lung point, which is where the pneumothorax ends. So when we are putting the M mode line right where the pneumothorax area is finishing, we can see the aerated lung coming in and out of the view. So this is where the lung is coming inside the view, and this is where the lung is going outside of the view. If we can see that, we can actually size the pneumothorax. We can see how big it is. Usually you can see it only in a small pneumothorax. Now, to increase the sensitivity of the ultrasound in trauma to pick up fluids, we can actually, for the upper parts of the abdomen, in the right upper quadrant and the left upper quadrant, we put the patient in the Trendelenburg position with the head down, and in for the pelvis, reverse Trendelenburg. And the good thing about EFAST is that it's non-invasive, no radiation to the patient, so we can repeat it, especially if the hemodynamic or other clinical features of the patient changes. Now, there are some pitfalls with the EFAST. The main one being pretty much, actually there are two quite common ones. One is that if there is some time past the trauma and the blood is already clotted, it might be echogenic, like this one there, and pretty much it might be mistaken with the rest of the soft tissue, but it's actually, you can see the kidney there. And this is what I was talking about earlier, that you might not be able to see the whole, pretty much 3 areas of the spleen, the diaphragm, and the kidney in one view, and you might need to sweep. But this is a kidney there, the spleen, and in between them, you can see the organ, the clotted blood there. Now, there's another pitfall. So one of these two images have blood in the Morrison's pouch and the other one doesn't. Can anyone say which one you think has the blood and which one doesn't? Anyone to make a comment? So this one has the blood in the Morrison's pouch, but this one doesn't. Both of them have this rim of anechoic area between the liver and the kidney. And if it is on the left side, it would be between the spleen and the kidney. But usually this happens in the right side. When you look a bit closely, you will see that in the image on the left side, you have this echogenicity of the liver. Then you have the black area, and then you have the hyperecho line, which is the kidney capsule, and then the cortex of the kidney, which is the same echogenicity as the liver. On this side, though, is the liver, then there is this hyperecho line, which was not present on that side. Then there is this anechoic ring. Then there is another echogenic area, which was present on this side as well, and then the cortex of the kidney. So technically, on the left image, we have only one hyperecho capsule. In the image on the right, we have two hyperecho areas. One, this one, and the other one is the capsule of the kidney. So this is called the double line sign. Excuse me. And when that happens, it's actually not free fluid, it's the pre-renal fat. When it is free fluid, it's just one hyperecho line. That is a very, very common pitfall, and I've seen it many, many times by people being called as positive EFAST for the free fluid, but it's actually just pre-renal fat. So you can see a bit more obvious example of it here. You can see the two hyperecho line, and that is because of the pre-renal fat. So most likely that the reason why that happened is that the acoustic impedance between the liver and the free fluid is not that much. So the interface between them is not going to be that hyperecho area. There's not going to be much of reflection of that interface because there's not much acoustic impedance difference. But there's a lot of acoustic impedance difference between the fat tissue and the cortex, or the fat tissue and the liver tissue. So the interface between the liver and the fat, and the interface between the fat and the renal capsule is going to be very, very hyperecho. That's pretty much it. Any questions?
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.